Welcome everybody. As people are finding their seats, I'll introduce myself. I'm Dave Usum from Johns Hopkins Hospital, and I have the pleasure of being able to introduce to you four of my good friends in neuroradiology who will be the presenters for the Essentials course in neuroimaging. I'm going to keep the introductions quite short so that way you can get the maximum benefit from these speakers. And our first speaker is Pat Hudgens from Emory, and she will be talking about sinonasal carcinoma, what not to miss. Pat.
I'm sorry? Okay. Thank you, David, and thank you to the program committee for asking me to speak today. I have been given 20 minutes to talk about what not to miss in sinonasal carcinoma, and I plan to spend the first 10 minutes on the boring old sinus CT. So if you're expecting glamorous arterial spin labeling or something else very high-tech, this may not be your 20 minutes. I have no conflicts that will impact this presentation. What I hope that you will gain from this is to recognize findings on the routine sinus or face CT that suggest a more malignant or aggressive process, such as a carcinoma. I'd like that you become familiar with characteristics of sinonasal carcinoma that might upstage or impact treatment without having to memorize a staging table. And for the most part, both CT and MR are virtually always needed to plan surgery or treatment for sinonasal carcinoma. And finally, I use each separate MR sequence for a different reason. I look at all the images, but I know that on a T1, I'm looking for something very different than on a T2 image. So I've chosen 4 ideas that I'm going to go through in a stepwise pattern. The first is those malignant or aggressive findings that may suggest something more aggressive or malignant, just as I said. Virtually all the cases that I'm showing here were missed. So these were all misses, all called sinusitis. One thing to remember is that as radiologists, when we're faced with a sinus CT, we often will look at the maxillary sinuses, and we all love to talk about that cyst or polyp in the alveolar recess. But don't forget that the nasal cavity is part of this area. And in fact, it's the sinonasal cavity or the sinonasal compartment. So we do have to look at all the sinuses, the integrity of the walls, but the nasal cavity is very, very important not to overlook. Unfortunately, sinonasal cancer, although rare, often presents in a very similar pattern or manner as infection or inflammation. So the referring doctor may be concerned about sinusitis or allergic rhinitis because the symptoms early on are the same. What that means is that we are the gatekeepers. We're the ones that have to be on our toes. We're the ones that know infection, inflammation can present just like a more malignant process. And in fact, for almost all sinonasal cancers, the very first study that patient got was a sinus or a face CT. This is the staging, the current staging for sinonasal carcinoma. I'll be going through some of this, but let me point out that a T1 tumor has no bone destruction. The number of times we see a T1 carcinoma is vanishingly rare. I think I've seen 1 in 30 years. Why? There's no bone destruction. There are no malignant characteristics. And this is a great guide for what you need to put in your dictation. It tells you what to mention. So the first that I'd like to talk about again is the malignant findings on a routine sinus CT. And I start with the nasal septum. Remember, the nasal septum, the posterior portion, is bone. So if you see it eroded, destroyed, that means bone destruction, and it's as significant as if one of the sinus walls were destroyed. Here's a patient with sinonasal carcinoma, and notice, yes, there's maxillary and nasal cavity opacification, and the mass does extend back to the nasopharynx. But look at this destruction of the nasal septum. There are areas of thinning, deossification, and frank destruction. By definition, that's an aggressive process. And in fact, that tumor is already in the contralateral nasal cavity, and you see that there as soft tissue. On this coronal CT, this was called sinusitis, the initial read, there are so many tip-offs that this is malignant. The medial maxillary sinus wall is gone. The turbinates and their insertions have all been destroyed. The lamina papyracea is thinned, deossified, and dehiscent. The septum has multiple areas of destruction, and the tumor is now in the right nasal cavity. And look at the anterior skull base. The normal cribriform plate here on the right is destroyed on the left. This thin bone, the lateral lamella, has completely been destroyed, and there are multiple areas of destruction of the ethmoid roof. This is not sinusitis. This is a malignant or aggressive process. Be sure to look at what sinus walls are missing. Here's a sinonasal carcinoma called sinusitis, and notice that the floor of the ethmoids has been destroyed. Here's another patient. This was called a mucocele, and perhaps part of this is a mucocele, but not all of it. This posterior maxillary sinus wall is, again, the words I like to use, I use them all the time, are thinned, deossified, dehiscent, and destroyed. And in fact, there are areas here where bone is destroyed. And notice this anterior wall of the sphenoid sinus is gone. That's destroyed. This is not sinusitis. Here's another patient. This was called sinusitis. And everybody thinks they can read a sinus CT. This was read by a sinus surgeon as sinusitis. And that's really not one of the choices. The sphenoid roof here is sclerotic, but you can see as we get to the right side, the roof is gone. The floor of this sphenoid sinus has been destroyed, and this intersphenoidal bony septum has multiple areas of destruction. This is not sinusitis, it's malignant or aggressive. Here's how I usually dictate these. These are my words. You don't have to use my words, but this is how I would leave an impression for this non-contrast CT. There is a left maxillary sinus and nasal cavity mass. That's pretty bold. Their malignant characteristics include nasal septal bone, posterior maxillary wall, and left anterior sphenoid wall destruction. Very concise, needs no further description. I don't need to say clinical correlation recommended. I'm telling them this looks malignant. There are sinus walls, especially at the anterior skull base, that can get very deossified, and they can get very deossified in the normal or aging patient. And I certainly always struggle with whether this is normal skull base thinning of aging or is destruction. But if you cannot see the base of the crista galli, as in this case, and you cannot see this perpendicular plate of the ethmoid bone, they're destroyed. This was called sinusitis. This is not sinusitis. You can see here that in the normal case, the cribriform plate should be well seen, and this is part of the perpendicular plate of the ethmoid bone, and it's destroyed there. This patient had an MRI within 12 hours, and here's the MRI. So this is a massive sinonasal esthesioneuroblastoma. Frankly, I don't usually give a differential. I come out and say this is malignant, and the next step would be blank, either MR or biopsy. But when you see these big intracranial cysts like this, it's a pretty good bet this is an esthesioneuroblastoma. This was read, and I have the dictation in my hand, as sinusitis. Other walls here are very thin or destroyed. There's another cribriform plate. Another example of destruction here of the nasal septum. And this tumor has now gone into the contralateral side. I'm not sure whether this is obstructed secretions or this is secretions. I'm not sure on this sequence. All I know is that this is not sinusitis. This too was dictated as sinusitis, and you can see this is from the same patient, and it's another esthesioneuroblastoma. This is how I would dictate it, and again, these are my words. I would say there's a right maxillary, ethmoid, and nasal cavity mass, period. And then I tell them why I think it's malignant. Malignant characteristics include destruction of the superior bony nasal septum, extension into the left nasal cavity, and bilateral cribriform plate and crista galli destruction. That leaves no room for error. I don't have to say clinical correlation recommended. We see the findings. Here's another patient that I showed originally, and you can see on the T2 image, we nicely see that that is all tumor in the maxillary sinus and extending back into the nasopharynx. Remember that from that staging template, the posterior maxillary sinus wall is very important. It upstages a patient with maxillary sinus cancer to a T3. So it's really important to mention which of the sinus walls are involved. Number 2, tumor versus benign secretions can be difficult to differentiate, and the single best sequence are the T2 images. Everyone goes for the gadolinium enhanced images, but think about it. Everything in the nasal cavity enhances normally. I use the gadolinium-enhanced sequences for 3 reasons: perineural tumor, intraorbital, and intracranial disease. Otherwise, I'm using the T2 images. The T1 images without contrast are so critical. You can see here this tumor is not in the subcutaneous tissues, and there's only very early involvement of the pterygopalatine fossa. I see many groups in my area put fat saturation on the pre-contrast T1 images. I would really recommend not doing that. You lose the beautiful high signal intensity fat. And this T2 image nicely stages the tumor. These are just benign secretions in the nasal vestibule and out laterally. This is in the zygomatic recess of the maxillary sinus, and the rest of this is tumor. How would I dictate this? I would say sinonasal tumor of the left nasal cavity and maxillary sinuses. I'd be sure in the malignant characteristics now to mention that the posterior wall is destroyed, and I would mention that it goes back into the nasopharynx. Again, I'm not giving a differential. It's so easy. Look how close this tumor is to the surgeon who can grab it with their biopsy forceps. I'm saying this is malignant. So I look for those aggressive findings, and then I might give a differential. All of these people have a malignancy of the sinonasal cavity. They're all malignant. Frankly, I can't tell one from the other, but I know this one's gone through the lamina papricia. This one is up in the olfactory recess. You can see it around the first cranial nerve. And this one has crossed that perpendicular plate of the ethmoid bone, and there is intracranial disease as evidenced by that vasogenic edema. A differential to me is not my responsibility. My responsibility is saying benign or malignant, where it's going, and where I think they can get the answer. Number 3, intraorbital or intracranial extension. That is really a very critical part of how to treat patients with sinonasal malignancy. Extension into the orbit, if there is extension across the rectus muscle and into this intraconal fat, many big centers will do an orbital exeneration. So I love the non-contrast fat T1 images. You can see here that the extraconal fat is preserved. The medial rectus muscle is preserved, and there is extension through the lamina papricia, but the tumor here is extraconal. On the T2 images, notice this very smooth interface with the intra or the extraconal structures. That is one of the buzzwords I use in my dictations to imply it is not intraconal. I say it has a very smooth interface with the extraconal fat. The gadolinium here doesn't help me at all. Even the benign secretions in the right ethmoids enhance. Intracranial extension is a very poor prognosis for sinonasal cancer, and it's very common. There are 3 imaging findings of intracranial intradural extension. These are the 3 findings. Dural enhancement over 5 millimeters has been said to have a sensitivity of 91% for intradural tumor. Focal nodularity carries a fairly high sensitivity and specificity. And the 3rd finding is loss of the low signal intensity line around the tumor, especially on T2 images. So if there's intracranial tumor, but it's extradural, most surgeons will still operate that patient and may pull that out of the intracranial compartment. But once these findings are present, they have a more focused approach and at least have access to neurosurgery if they think that they will need to get intradural. Even all these factors together, it is said that there is only a 16% chance of being intradural. So rarely should those findings necessitate not going to the OR, because some of them, you still have a 16% chance of no intradural extension. This project desperately needs to be redone. So let's look at some of those findings for intracranial extension. Here is a nodular intracranial extension of this massive sinonasal tumor. There's over 5 millimeter thick enhancement right here. These are 2 of the imaging findings that suggest there is intradural disease. We see that low signal intensity line, and there, it's gone. All 3 findings of intracranial intradural disease are present here. Here's a patient with a sinonasal malignancy with a big nodule that is intracranial. And remember, nodular extension carries a fairly high predictive, it's a fairly high predictive finding for intradural tumor. And this patient really has all 3. Has a nodular component right here, over 5 millimeters of thickness here, and the word I like to use for this appearance is a feathery interface. So when I'm looking at the orbit, I would say here it has a smooth interface, but feathery in my mind means likely intradural extension. So all 3 of these patients had documented intradural tumor. Here is a patient who's already been operated, who has had a resection there on the right, and you can see this feathery interface between the brain and this recurrent tumor. Here's a patient with over 5 millimeters of intracranial dural enhancement. That's one of our malignant and intradural findings. And here's a patient with the low signal intensity line around the base of the brain, and there it's interrupted, and there is tumor that was intracranial and intradural. The 4th finding, which I am not going to spend as much time on because we will have a beautiful discussion of perineural tumor, is very briefly is perineural tumor spread. Every sinus and every face CT has so many neural foramina that it's just so critical to be looking at these and not just the maxillary sinus mucosal cysts or polyps. This was called normal sinus. You can see back here there's a normal palatine foramen at the back of the palate. Look at it here. The floor of the nasal cavity is destroyed, the greater palatine foramen is widened, and soft tissue is extending up the Vidian canal. This was called normal. Here's a patient that was called normal, and look how close the supraorbital foramen is to the frontal sinus. So when we're doing sinus CT, we may not be aware of it, but we see the supraorbital nerve and foramen on every single case. If you live in a place where there's a lot of sun exposure and see a lot of skin cancer, you are probably very familiar with this perineural tumor coming back along the first division of the 5th cranial nerve. This was called normal. So just briefly, those areas you want to look for are bone destruction. The posterior maxillary sinus is a very important landmark. the orbital walls, and the cribriform plate. Get used to looking at the pterygoid plates. Involvement or erosion by any process upstages the process to at least T4A. And notice that the anterior orbit tumor and orbital apex extension are different and carry different staging, with orbital apex being very serious tumor. Our job, in my mind, is to look for those malignant findings and to look for the extent of tumor, whether the cheek, retroantral fat, or up into the orbit or the sphenoid sinus. So the four things I've emphasized: look for bone destruction. This is not benign. There's destruction of the skull base. Use the T2 images to decide what is benign and what is malignant once you've decided it's a tumor. Intraorbital or intracranial extension, I like the words feathery or smooth. And finally, perineural tumor is critical to look for, and all of these important foramina are on every single sinus CT. Thank you.
Fantastic and uniformly outstanding as always. Our next speaker is a close friend and colleague of mine and is our guru of the skull base. Ari Blitz from Johns Hopkins will give our next talk.
Thank you, Dr. Yusum, and thank you for the honor of the invitation. So as Dr. Yusum mentioned, I'll be talking to you today about high-resolution 3D imaging of the cranial nerves, and I'd like to share with you our segmental approach to cranial nerve imaging. I do have some updated disclosures. So by the end of this talk, I'd like you to be able to list the segments of the cranial nerves and describe methods of visualization of each segment, including on high-resolution 3D imaging. I'd like you to be able to describe some of the common tumors arising from the cranial nerves, as well as tumors of the head and neck with a tendency for perineural spread of disease. And I'd like you to be able to identify some of the imaging features of primary tumors arising from the cranial nerves, as well as perineural spread on cross-sectional imaging. First, we'll have this introduction. We'll talk about the segmental nomenclature that we've developed. We'll talk about the general MRI technique for 3D high-resolution imaging. We'll then turn our attention to describing the various cranial nerve segments. And for each segment, we'll talk about the imaging approach for that segment. We'll talk about some of the normal anatomic images as well as some of the pathologic cases, and then there'll be a brief summary. So first, to talk about cranial nerve anatomy, the cranial nerves can be divided up into segments, and they pass from, we should realize, the brainstem out into the space outside of the skull. And as they progress through these different contexts, anatomic contexts, the imaging challenges for us change depending upon what portion of the cranial nerve we're talking about. And so we can divide the cranial nerves in a generic sense into the nuclear segment, the A segment within the brainstem. We can talk about the B segment, the parenchymal fascicular segment, where the nerve fiber bundles course together in the brainstem. Then the nerve exits the brainstem at the surface of the brainstem at its apparent origin to enter the cisternal segment, where it is surrounded by cerebrospinal fluid in the subarachnoid space. The nerve then comes into close contact with the inner layer of dura without piercing the inner layer of dura. As you know, there are two layers of dura. There's an inner or meningeal layer and an outer or periosteal layer. So first, the nerve gets into close proximity with the inner layer of dura in the dural cave, the D segment, and then for our purposes as radiologists, it passes through the inner layer of dura into the interdural segment between the inner and outer layers of dura, where it's surrounded by a potential space with venous blood. The nerve then has to get out of the skull, passing through the bony canal through the F or foraminal segment into the G or extraforaminal segment outside of the skull. And we can refer to the segments of the cranial nerves by shorthand with the cranial nerve number and that extension after the period. This allows us to provide a concise and standardized means of communication with our clinicians. And it has implications for differential diagnosis and can alter our imaging approach to visualizing the part of the cranial nerve that we're interested in. In fact, we'd like to visualize as much of the cranial nerves as we can, and the protocol that we would suggest for this purpose is the one that I'm going to show you, that includes 3D high-resolution isotropic imaging, which allows us to acquire images in one plane, typically the axial plane, and reconstruct those images, of course, in the coronal and sagittal dimension post hoc. Our protocol includes pre-contrast T1 weighted imaging, which is done without fat saturation for the reasons that Dr. Hudgens mentioned. And here we have cis imaging, which is a steady-state free precession sequence, which has mixed weighting. And then we use T2 stir space imaging. After contrast, we do post-contrast 3D T1 high-resolution imaging with fat saturation now to increase the conspicuity of enhancement. And we do post-contrast cis imaging as well. We get our T1 imaging appearance from the 3D, in our case, vibe images. Here's a mass of the clivus, which is T1 hypointense, a chordoma, and here it is on the stir space imaging looking T2 hyperintense. After contrast, it enhances, but it's really the cis imaging before and after contrast, which is the heart of this protocol, which allows us to see the highest amount of detail. So cis imaging is, as I mentioned, a type of steady-state free precession imaging equivalent to Fiesta-C or balanced fast field echo images on other vendors. It's a highly SNR efficient sequence, and although it appears T2 weighted, in fact, it has mixed T2 over T1 weighting. And we're performing the stir space images at 1 millimeter, vibe the T1 at 0.8, the cis imaging at 0.6 millimeters, and the same after contrast. So now to turn our attention to the different segments of the cranial nerves. First, to talk about the A and B segments, the nuclear and parenchymal fascicular segments. These are surrounded by brainstem parenchyma. We're not able to see them well on standard imaging, and we have to infer their location with respect to known landmarks. Sometimes we can use DTI to see them as well. So here's a patient with a right superior oblique palsy. They have an area of restricted diffusion in the left midbrain below the cerebral aqueduct. And we know from our knowledge of anatomy, this being a dorsal dissection of the brainstem with the pineal gland, the superior colliculi, the inferior colliculi, we know that the fourth nerves, for instance, arise just caudal to the inferior colliculi, and we can infer from that anatomic knowledge where the nuclei should be and the parenchymal vesicular segment should be. And so this is the location of the fourth nerve nucleus on the left. This patient had a stroke of their left fourth nerve nucleus, recalling that the parenchymal vesicular segments decussate for the fourth nerve and before leaving the brainstem, and being the only cranial nerve to exit the dorsal aspect of the brainstem. Now turning your attention to the C and D segments, the cisternal and dural cave segments. These segments are surrounded by cerebral spinal fluid. They're very well visualized on thin section T2 weighted imaging, and including 3D steady-state free precession imaging, first described by Dr. Kasselman, who we'll be talking to in just a few minutes, or on other T2 weighted techniques such as space. And here I should mention that the cranial nerves have to extend from the central nervous system to the peripheral nervous system, and the central nervous system is myelinated by glia, and demonstrated here in black on this ventral view, this ventral cartoon, whereas the peripheral nervous system is myelinated by Schwann cells. This has implications for our differential diagnosis. The point of transition between the two is sometimes termed the transition zone or the Obersteiner-Redlich zone, and the fibers of the central nervous system are referred to as tracts, the peripheral nervous system as nerves. Now notice in this image that the first and second nerves are properly tracts rather than nerves. Here's the cisternal segment of the third nerve, the oculomotor nerve, extending from the interpeduncular cistern anteriorly, medial to this surface landmark of the temporal lobe, the uncus. Here it is in the coronal view, reconstructed from the axial view, passing underneath the posterior cerebral artery and above the superior cerebellar artery. And here's a case, a pathologic case. This is the midbrain. Here's the pons, midbrain and pons. And here's the third nerve extending anteriorly. Notice how it fans anteriorly from 1 millimeter to about 1.5 to 2 millimeters anteriorly. It is also on post-contrast cis imaging. This is pre-contrast cis imaging. On post-contrast cis imaging, we can see that area of expansion enhancing on cis imaging. And in fact, that's due to compression from an aneurysm in this case. Here's a coronal reconstruction where I fused the MRA to the cis imaging. We can use high-resolution imaging to determine the relationship of the cranial nerves to masses, very useful for preoperative planning. Here is a suprasellar meningioma enhancing on this coronal T1 weighted image, but we cannot see the optic nerves all that well. After we give contrast on cis imaging, however, notice the displacement and deformity of the optic nerves on either side adjacent to this meningioma. More typically, we're looking at schwannomas in the subarachnoid space, and here are bilateral filling defects within the fluid of the internal auditory canal, enhancing after contrast. And these are, of course, bilateral schwannomas in the setting of neurofibromatosis type 2. Schwannomas are the most common peripheral nerve sheath tumor, followed by neurofibromas. These are focal and well-circumscribed lesions. They tend to expand rather than erode and push different structures aside. When they're very large, they can undergo cystic degeneration. They don't calcify very frequently. Neurofibromatosis type 2, as you know, is also known as the Misme syndrome for multiple inherited schwannomas, meningiomas, and ependymomas, and bilateral eighth nerves, as in this case, eighth nerve schwannomas are diagnostic. So these masses of the eighth nerves, because of the transition zone between the central and peripheral nervous system, cannot occur, vestibular schwannomas cannot occur principally within the cister. They have to be at or beyond the porus acousticus, because the eighth nerve here is atypically has an elongated central nervous system component. Next, we should talk about the dural cave segment. And we're used to thinking about, here in this axial cis image, here's the pons and the fifth nerve, the trigeminal nerve with the dural cave segment. The largest of the dural cave segments is, of course, Meckel's cave. Here we see it in the axial view, but we also know that the other cranial nerves have dural caves as well. Here's the dural cave of the third nerve on pre-contrast cis imaging in the coronal and sagittal planes. Turning our attention now to the interdural segment, once the cranial nerve has pierced the inner layer of dura but has not yet passed out through the outer layer of dura, it's in the interdural space between the inner and outer layers of the dura mater, surrounded by venous blood. In this segment, this part of the cranial nerve is not well visualized on traditional T2-weighted images, and here we need to use contrast-enhanced imaging. And contrast-enhanced steady-state reprocession images such as cis imaging are really ideal for this purpose. Here we have a cis image before contrast. This is the midbrain, the pons, the medulla, and the sagittal plane. And you can see the sixth nerve here extending anteriorly and superiorly in the cisternal segment and up to the dorsum of the clivus, and you can't see beyond that. In the axial plane, here are the six nerves as well. But once we give contrast, we can see the sixth nerve almost in continuity from the brainstem out into the orbit. And that's because of the enhancement on cis imaging of the interdural space, of the venous space surrounding the nerves. And so in the coronal section, we can now see in the interdural space in the cavernous sinus, after contrast on cis imaging, we can see the interdural third nerve, the interdural fourth nerve, the sixth nerve. Here's the first portion of the trigeminal nerve and the ophthalmic division, and here's the maxillary division of the trigeminal nerve. This is a very useful technique for surgical planning and understanding the relationship of masses to the adjoining cranial nerves. Here on the right side, we see the cisternal segment of the abducens nerve. And the question is, here with a mass, an extraaxial mass on the patient's left side, where is the sixth nerve in this case? After we give contrast, we can see that the mass enhances intensely on post-contrast cis imaging, and now we can see the inner layer of dura as distinct from the interdural space, which has enhanced. We can see the left sixth interdural nerve here, interdural sixth nerve, as demarcated by the arrow, as shown by the arrow, as separate from that mass by 1.5 millimeters in this particular case. The patient did not have an abducens palsy preoperatively and was successfully operated on. This meningioma was removed, and the patient did not have an oculomotor palsy postoperatively. Here's another pathologic case. We can see on the patient's left-hand side, here's an axial image through the pons on post-contrast cis imaging. The arrows demonstrate the left interdural sixth nerve, passing from the petroclival segment under Gruber's ligament into the cavernous sinus here on the left side. Where is the nerve on the right side? Well, the nerve on the right side is not seen because it's pathologically enhancing. Standard imaging in this case was normal. The patient presented with a right sixth nerve palsy. We can see in the sagittal view the cisternal segment coming up, a short dural cave. And here's the proximal interdural segment. The remainder of the nerve is not well seen because it's pathologically enhancing, surrounded by venous enhancement in the interdural segment. This is a case, a VIP patient who was presented to us with trigeminal neuralgia. And they were being referred for neurovascular decompression. They had had multiple different imaging studies at an outside institution. And here's the outside study. It was normal, or judged to be normal or near normal, perhaps some subtle asymmetry of Meckel's cave on the right side. After contrast, on high-resolution imaging, however, you can see on the cis imaging in the coronal section post-contrast, this is the normal maxillary division of the trigeminal nerve. It's black, it's dark, it's not enhancing. The cranial nerves, with the exception of the ganglia, do not normally enhance. But here on the right-hand side, there is no normal dark nerve in the where the V2 interdural segment ought to be. The nerve is pathologically enhancing, and you can see on the post-contrast coronal T1 weighted sequence that it's also somewhat enlarged. This was a case of adenoid cystic carcinoma, perineural spread of adenoid cystic carcinoma. The patient needed not a neurovascular decompression, but treatment for their malignancy. Perineural spread of malignancy is the radiological equivalent of perineural invasion, the histologic term that's applied. It's extension of tumor along the cranial nerve, between the cranial nerve and the perineurium, and there's thought to be some tropism between the nerve and the tumors, which can spread in this way. The perineural spread can infiltrate fat pads at the base of the skull, and we ought to evaluate the fat pads at the base of the skull, but we now view this as a relatively late sign in some cases, and I'll show you an example of that in a few minutes. Squamous cell carcinoma is the most common malignancy to demonstrate perineural spread in the head and neck, and this is because it's the most prevalent. Adenoid cystic carcinoma, on the other hand, per tumor, is much more apt to demonstrate perineural invasion. About 50% of the tumors do demonstrate perineural invasion histologically, with a very poor prognosis and higher rate of recurrence when that's seen. Basal cell carcinomas, melanomas, mucoepidermoid carcinomas, and lymphomas can also produce perineural spread of malignancy. And the skull base forms a barrier to prevent entry of malignancy into the intracranial compartment, but perineural spread allows tumors to more easily extend into the intracranial compartment, and is important for that reason additionally. The perineural spread, of course, begins in the extraforaminal segment, the G segment, and extends into the intracranial compartment uniformly. Turning our attention to the foraminal segment, here the nerve is again surrounded by venous blood. There's a venous channel surrounding the nerve, and also surrounded by bone, of course. This is not well visualized on traditional T2 weighted images, and here again we can use contrast-enhanced steady-state free precession images to visualize the nerves in the foraminal segment. Here's a demonstration in the sagittal view after contrast on cis imaging of the third nerve. Here's the midbrain, the pons, and the third nerve extends anteriorly. Here it is in the cavernous sinus, extending into the superior orbital fissure anteriorly. In the coronal plane, we can see the various nerves in the superior orbital fissure in the foraminal segments. Here's the V2 segment of the trigeminal nerve extending anteriorly through foramen rotundum, and here it is in the coronal plane, again seen as a nice dark structure without enhancement. In the foraminal, so here's a case of foraminal segment pathology. Here's a mass in the right optic canal. And of course, this cannot be a schwannoma. We know from the earlier cartoon that I showed you that the optic nerve is properly a tract of the central nervous system. This has to be an optic nerve glioma. Here's a case of a another foraminal case, a patient with right-sided visual loss coming to us from an outside institution with a history of optic neuritis. This was interpreted at our institution by a very experienced neuroradiologist. And given the history of optic neuritis, perhaps not surprisingly, the diagnosis given was that of optic neuritis. It didn't quite fit clinically, however, and the patient was referred to us for high-resolution imaging. And here we can see on the right side, on post-contrast fat-suppressed, in this case T1 space imaging, a mass with dural tails on both sides. In the axial post-contrast cis imaging, you can see that this mass actually deforms the adjacent optic nerve in the optic canal. And here's the arrow is pointing towards the mass. This is therefore not optic neuritis and was taken to surgery. So here is an endoscopic view. The bone has been removed. Here's the dura overlying the optic nerve on the patient's right side. Here the dura has been incised. And this mass is a meningioma and is being taken out in this figure. After the meningioma has been removed, we can then see the optic nerve in the optic canal decompressed. And this patient, I'm glad to say, did regain vision after the surgery. The extraforaminal segment, in the extraforaminal segment, the nerves are surrounded by fat and different tissues, including the salivary glands. Here, with a high-resolution image through the orbit with a surface coil, you can see the inferior division of the extraforaminal oculomotor nerve just underneath the optic nerve. And here it is in the axial plane innervating the medial rectus muscle. This case was sent to us from an outside institution, well-known outside institution with a diagnosis, the patient of a left optic nerve glioma. Here on the normal right-hand side, you can see the optic nerve, and underneath it, the extraforaminal inferior division of the third nerve. On the left-hand side, the mass is demonstrated with the asterisk. The arrow points to the optic nerve, which is displaced superiorly. This is not an optic nerve glioma. It was a schwannoma of the inferior division of the extraforaminal third nerve. I want to next show you the facial nerve in the extraforaminal segment as an example. Here in sagittal section, we can see the facial nerve on high-resolution imaging. Here it is anterior to the left of the screen, posterior to the right of the screen. Here it is exiting the stylomastoid foramen and passing into the parotid gland, here demonstrated with the P, and branching in the parotid gland. We can see the facial nerve itself in the parotid gland, and we no longer need to rely directly on the landmarks, including the retromandibular vein here in the axial plane with the arrowhead that we needed to rely upon in the past. Here's a pathologic case of the extraforaminal seventh nerve. Here's a mass, the same orientation coming out of the stylomastoid foramen and extending into the parotid gland. And notice here, the mass is enhancing on post-contrast cis imaging, and here is the facial nerve extending directly from the mass itself into the remainder of the parotid gland. So this is a mass arising from the nerve itself. This is a facial nerve schwannoma. Contrast that with this case, same orientation. We have the stylomastoid foramen here, and here there's a mass, an enhancing mass in the parotid gland, and here the nerve extends from the stylomastoid foramen and it's draped over the mass. And this implies that the mass is separate from the facial nerve. In fact, this was an adenoid cystic, a pleomorphic adenoma of the parotid gland. The last case here, this is a patient, again, in sagittal section through the parotid gland, and here we have the facial nerve exiting the stylomastoid foramen. And as it continues towards the parotid gland on this post-contrast imaging, suddenly we don't see it any longer. And why don't we see it any longer? In a manner analogous to that case I showed you of the interdural sixth nerve, we don't see it any longer because the nerve is pathologically enhancing. And this is a case of perineural spread of a basal cell carcinoma in the facial nerve within the parotid in the extraforaminal segment. So the key points, we can divide the cranial nerves into different segments based on their environment, and each segment has different imaging strategies which should go along with it. The protocol that I've shown you allows for visualization of much of the cranial nerves from their origin, their apparent origin at the brainstem into the extraforaminal segment. The protocol that I've demonstrated can be performed in approximately 25 minutes. And importantly, the imaging technique, of course, has to vary by segment. I'd just like to acknowledge some of my colleagues from neurosurgery, ENT, neuroradiology, and biomedical engineering. And most importantly, perhaps, again, Dr. Strollo and Dr. Yusum for the invitation. Without Dr. Yusum's friendship and support over these years, I certainly wouldn't have been having the privilege of talking to you here today. Thank you.
Oh, yes, he would have. He's doing it all on his own. So, our next speaker is another good friend, Minerva Becker. She used to be the queen of imaging of the larynx, but we've recycled it, and now she's going to be the queen of imaging of the orbit. So I'm looking forward to hearing that.
Okay. Thank you very much, David, and thank you very much for the organizing committee for inviting me to give this lecture. Now, I have nothing to disclose, and during this lecture I will try to give you a simplified approach to the differential diagnosis of orbital lesions in adults. Now, first of all, a few facts regarding orbital masses in adults. They are relatively uncommon, and 2/3 of orbital masses are benign and about 1/3 are malignant. They have, however, very similar clinical findings, and therefore characterization of these orbital masses with cross-sectional imaging is crucial because patient management is going to depend greatly on the dignity of the mass. Now, in order to make a meaningful differential diagnosis, you have to be familiar with the compartment-based approach of the orbit. You know that the extraorbital muscles, the extraocular muscles form the cone, and this cone, the muscle cone, divides the orbit into an intraconal and an extraconal compartment. Within the intraconal compartment, we have the posterior half of the globe, we have the optic nerve sheath complex, we have fat, then we have cranial nerve 3, 6, 5, 1, and then we have vessels. And in the extraconal compartment, we have fat, we have the lacrimal gland, and the bony walls of the orbit. Now, if we look now here at the orbital septum together with the lid form the preseptal compartment, and the lacrimal sac is actually located in this preseptal compartment. Once you have identified a lesion in one of these compartments, you have already narrowed down your differential diagnosis. And the next step is to try to identify specific morphologic features. We have a group of lesions in the orbit that have very specific morphologic features such as uveal melanoma, meningioma, hemangioma, dermoids, and we have lesions with overlapping morphology. Now let's start with those lesions that have specific morphologic features. The most common primary intraocular tumor in adults is uveal melanoma, and it has the highest incidence in Caucasians about the age of 53 years. If you look at CT images in patients with uveal melanoma, they are hyperdense, there are no calcifications, and then you will see very strong contrast enhancement even in very small lesions. On MRI, due to the melanin content, these lesions have a very high signal on fat-saturated T1, low signal on T2, and they have this characteristic mushroom-like appearance. When you perform diffusion-weighted imaging with ADC maps, then you see that due to this high cellularity, the ADC values are going to be relatively low, and it is important to obtain these ADC values because patients with uveal melanoma will undergo proton therapy, and if the proton therapy works, then the ADC value is going to increase very early during treatment. However, the mass will decrease only later on, at least 6 months later after treatment. Regarding optic nerve sheath meningioma, these are the most common tumors arising from the optic nerve sheath in adults. We see them in females, and we have the primary form that arises from the intraorbital optic nerve from the canalicular segment, and then we have the secondary optic nerve sheath meningiomas that spread from intracranially into the orbit. Characteristic findings are this tram track sign that you see on T2, on T1. There is encasement of the optic nerve. You see on this DTI image how all the fibers are actually atrophic due to the meningioma, and on coronal images you have this target sign. If you do diffusion-weighted imaging, these tumors have a high cellularity, typically below 1. They may mimic malignant tumors, however, rely on your morphology because this is characteristic. Another characteristic findings is also the fact that they have these calcifications, these tram track-like calcifications. This was actually an incidental finding on a cone beam CT. The patient afterwards underwent MRI, and you see this meningioma. Now, cavernous hemangiomas are the most common benign tumors in adults, and they're typically located in the intraconal space. They're called venous or low-flow vascular malformations. Sometimes they're associated with varices or with lymphangiomas. Now, what's typical of these lesions? They have an intermediate signal on T2, they displace the optic nerve. On fat-saturated T2 or on STIR images, high signal, and you see the ADC value is above the limit for benign lesions, and also these hemangiomas have this patchy enhancement that you see on early images with progressive filling on later sequences. You can also see these features on CT, for example, in this case here, patchy filling initially and then progressive filling in the venous phase. Some hemangiomas have phlebolith, but not all of them. The most common extraconal tumor in the orbit is dermoid, and the one feature that's important to be aware of is that these lesions tend to rupture, and there will be inflammation in the orbit, which predisposes to local recurrence. How do we make the diagnosis? Well, we have a cystic lesion that contains fat. You see here that the anterior portion has high signal on T2, on T1. The signal disappears on fat-saturated images. There's also some fluid droplets. This is fatty content. The posterior portion is, however, it has some other fluid contents. And if you do diffusion-weighted imaging, due to the fatty content, you will have very low ADC value in this fatty content and a very high ADC value in the cystic content. Therefore, your ADCs is going to be to vary tremendously. Now let's have a look at those lesions that are difficult to diagnose because morphology is overlapping. In terms of lacrimal gland masses, we have a 50% rule. 50% of these lesions are epithelial, 50% are non-epithelial. And then if you go back to the epithelial lacrimal gland masses, about 50% are pleomorphic adenomas, benign, 50% are malignant, typically adenocarcinoma, ductal carcinoma, adenoid cystic carcinoma, and many more. Now let's have a look at what's so typical for pleomorphic adenoma of the lacrimal gland. Most of them are have a higher cellularity than in the salivary glands. They have a non-specific aspect on T1 and a very strong enhancement after gadolinium. And they have pseudopods. These pseudopods typically tend to remodel the the roof of the orbit, and pseudopods are actually well known in the histologic literature. You have to look for them carefully, especially on thin slice images. Another important feature is the fact that these tumors have relatively high ADC value because they do not have a very high cellularity. This is very useful, especially if you have confounding morphologic features. Another case here, you see this bizarre looking tumor in the lacrimal gland, hyperintense on T2, non-specific on T1, on STIR, irregular enhancement with necrotic appearing lesions on the FAT-SAT image. And if you look at your diffusion weighted sequences, you see there is no restriction of diffusion, high ADC value. This is pleomorphic adenoma. Now, the most important feature to differentiate pleomorphic adenoma from carcinoma is restricted diffusivity. So if your ADC value is below 1 or 1.1, then you should consider this as your first diagnosis. An example here, this is a patient with an irregular appearing tumor in the lacrimal gland, hyperintense areas, non-specific on T1, inhomogeneous enhancement on the diffusion weighted sequence per thousand, and the ADC value, you see this very low value suggesting malignancy. Now, why is this tumor so irregular on T2? It is because it has calcifications. And calcifications are very common, actually, in adenocarcinomas, ductal carcinomas. This here was a mammary analog secretory type of carcinoma that's been recognized as a new entity, quite common in lacrimal glands. And it's very important not to misdiagnose these calcifications as phlebolyth, as this was initially read. Also, another important point to keep in mind is that carcinomas in the lacrimal gland have a very slow growth pattern. Therefore, you will have bony scalloping. You see here this deformity of the orbit. Don't mistake this for a benign lesion. Now, the last part of my lecture is about how to differentiate lymphoma and inflammatory orbital pseudotumor. Lymphoma is the most common orbital malignancy, 55% of malignant adult orbital tumors. It's mainly found in elderly patients. 75% of lymphoma patients have systemic disease, and it is associated, it is much more common in patients with Sjögren's disease. Now, what about inflammatory orbital pseudotumor? It is also called idiopathic orbital inflammation, and clinically, these patients have a painful orbital mass. It is third most common orbital disease. Patients are a little bit younger and responds well to steroids. Now, if we look at the anatomical patterns, you see they are very similar in lymphoma and in orbital pseudotumor. So this does not help us very much. But let's have a look at the morphology. In lymphoma, as you see here, a lymphoma rising from the lacrimal gland, we have a very homogeneous T1 signal, homogeneous T2, intermediate, and then we have homogeneous enhancement. If you look at your ADC map, you see very low ADC values, typically in the range of 0.5 to 0.8, so actually much lower than the values for carcinomas. You also will see that these patients tend to have a very high SUV value. What about further manifestations of lymphoma? Sometimes you will see that lymphomas present with the so-called casting sign. You see there is this diffuse infiltration of the orbit. The optic nerve is encased. There is actually ischemia of the optic nerve. We see also an increased fractional anisotropy on diffusion tensor imaging. And after injection of contrast material, we see extension intracranially into the cavernous sinus, extension along V2, into Meckel's cave, extension into the pterygopalatine fossa, and into the soft tissues of the cheek. Now, if you look carefully here at these soft tissues, this was where the original biopsy was obtained. And in this area here, look at the ADC value. You see that the ADC value is actually much higher, and you don't have any FDG uptake here. It was more convenient for biopsy, but this is actually a sampling error for your biopsy, and only a second biopsy that was later on performed where the ADC value were lowest and the SUV values were highest was actually diagnostic. As I mentioned previously, 75% of orbital lymphomas have distant involvement. Therefore, PET-CT should be done in all of these patients. Patient here with an orbital lymphoma of the lacrimal gland and with a supraclavicular lymph node metastasis. And don't forget that we may discover orbital lymphoma incidentally. This patient here was imaged because Sjögren syndrome was suspected. You see this characteristic aspect of the salivary glands, and incidentally we found a lymphoma of the lacrimal gland. Now, what about inflammatory orbital pseudotumors? It has many features that are quite similar in terms of morphology to lymphoma. For example, unilateral disease is much more common than bilateral disease. All of these are inflammatory pseudotumors. We have extraconal and conal involvement is much more common than the casting sign. Another feature that you can also have in inflammatory pseudotumors is intracranial spread. You have this patient here with an inflammatory pseudotumor extending into the cavernous sinus, another patient with bilateral inflammatory pseudotumors destroying the skull base extension into the cavernous sinus, into the dura and Meckel's cave. Multiple site involvement occurs in up to 20% of patients with inflammatory pseudotumors. As you can see here, this patient has an inflammatory pseudotumor and also involvement, so not only of the lacrimal gland, but also of the submandibular gland. But the features that really allow you to make the differential diagnosis between the two are straightforward. You have actually this patient here has an inflammatory pseudotumor, this one has a lymphoma. In inflammatory pseudotumors, you have much lower T2 signal in the affected area as compared to lymphoma, and the ADC value are much higher in inflammatory pseudotumors than in lymphoma. Now, if you transform this gray scale ADC maps into color-coded ADC maps, the same patients, this is what you get, and you see that inflammatory pseudotumor, you will have much more heterogeneity in the lesion, different colors. If you look at lymphoma, this is more homogeneous. And then if you try to make a histogram analysis and all the pixels that are here, you plot them, the ADC values, and you look at the frequency, you see that in inflammatory pseudotumors, you will have actually a relatively flat Gaussian curve, which is relatively broad. However, in lymphoma, it will have a very high peak. The mean ADC value is much lower, and you see that the curve is is not very broad. So this is quite characteristic. Now, what does this help you? Well, it helps you when you are not sure about your differential diagnosis. We have an example here, a patient with bilateral disease, non-specific infiltration of the orbit, hypointense on T1, different types of enhancement after gadolinium, not specific. If you look at your T2 weighted sequence, a very low signal, so this is actually already suggesting an inflammatory pseudotumor. But if you measure now your ADC values, well, this is about the value 1, so it's actually a little bit too high for lymphoma and a little bit too low for inflammatory pseudotumor. So what do you do? Well, doing your histogram analysis, you see this characteristic broad shape that does not have the typical appearance of a lymphoma. So what are the take-home points I'd like to give you? First of all, if you look at orbital masses, use as a first approach the classic space-based approach. Then carefully analyze your morphologic MRI images, because they will already enable you to make the diagnosis of a variety of images, of a variety of tumors, namely melanoma, meningioma, hemangioma, dermoid cysts, etc. Look at perineural spread, intracranial and multiple head and neck site involvement with morphologic imaging. Add diffusion-weighted MRI to improve your sensitivity and specificity for the differentiation between benign and malignant lesions. And last but not least, help your surgeons to plan the biopsy, because using multiparametric imaging by choosing those areas where you have the lowest ADC and the highest SUV from PET-CT, you will avoid sampling errors for histology. Thank you.
All right, so now for our next treat, we have a good friend from Belgium, from Bruges, Jan Kasselman. I love listening to him talk, and I'm sure you're going to enjoy his speech on the temporal bone. Oh. You better do it.
Start. So first I would like to thank the program organizers and especially David for the invitation. And I was asked to talk to you about the congenital and inflammatory disorders of the middle ear and inner ear, and especially MR in these areas. So let's start. And first of all, if you look at the inflammatory and congenital disorders in these areas, CT has a very important role. But today I'm going to talk to you where MR plays a role, where MR makes a difference. And therefore, we are going to look also at the techniques. What kind of MR will you use, and where do you really have to use MR instead of CT? Now, if you look at the congenital disorders of the middle ear, well, there are few. So I think most of the things you will look for are CT, to look at the ossicles, the cavity, the aberrant course of vessels, and so on. So that's all CT. There are only few MR indications, and one of the most important one is tissue characterization. You will now and then find in a normal aerated ear with a normal drum, you will find a nodule. And when this nodule is medial to the ossicles, that's not an acquired cholesteatoma. Then you are dealing with a congenital cholesteatoma. The best way to characterize it, just use non-EPI MR, and that will give you a high signal. I will come back to you. That proves it's a congenital cholesteatoma. It's there from the beginning, embryologically, skin in the wrong place. Now, in the inner ear, of course, their MR has a much higher impact. And what we will do, well, we will look for the visualization of labyrinthine malformations. Okay, CT can do that as well, but today we use also MR. There are two classifications that are used that you should know. The old one is Jackler's classification, where we look at the embryological arrest. So when something goes wrong in the embryology, it stops growing and you have severe malformations. But today we know that most of the malformations are genetic. And that's a new classification you should know, the Senaroglu classification, which is much more clinically driven. Now, The second point that we are using the MR for is to look at the 8th nerve. And there's no alternative. CT has no role there. So there we have to use MR. So overall, if you want to look at your inner ear, it's better to start off immediately with MR because you can see and the congenital malformations of the ear and you can look at the nerves. Now, the Senaroglu classification actually gives you 3 big groups. The severe malformations, aplasia of the labyrinth, of the cochlea, the common cavity. And then you have the incomplete partitions, where the inside of the cochlea is completely abnormal, 3 types. And then you have the hypoplasia of the cochlea, where the cochlea has not enough turns, is too small, so that's the hypoplasia. Now, I give you 2 examples. Here we have just the basal turn, and the apical and the second turn are confluent. You see that on the abnormal side. On the normal side, we have the apical, second, and basal turn. So this was called in the past the Mondini malformation. You see that we have a hypoplastic modiolus. You see that, so here it goes wrong. And if you look inside the cochlea, the normal side, you see the modiolus, and you see the scala tympani vestibuli, but on the other side, the abnormal side, you have no modiolus, and the interscalar septate, they just bow down. So it's an abnormal scala separation. So you see more on MRI, you can really have a look inside. And this helps the surgeon, because if he knows that, he says, I have a normal basal turn. If it's a IP type 2, I can put in an implant, and it can be any implant, it will work. So they know what to use just from the classification. This is a type 3 IP. And here you see that we have an internal auditory canal that just continues in the cochlea. It was called the X-linked in the past. Now, if you look on MR, you see the nerve going in and it's just separating. Instead of the modiolus, the nerve fibers go to the wall of the cochlea. So where are the nerve fibers? Not in the center, at the periphery. So a hugging implant will not work. You will need one that opens and has ring contacts so that you find the nerve fibers where they are at the wall. Also, you see that there is no separation between the CSF and the cerebral pontine angle and the cochlea. That means you get a gusher ear. So you have to be careful. The surgeon knows that. If you say type 3, he knows that, and he knows that he has to seal the cochlea after putting the implant, or he has a gusher ear, a leak, and he can have meningitis. And he also knows that he has to use a short implant with ring electrodes, not too long, or he will stimulate inside the internal auditory canal the facial nerve. So the classification is really fantastic. And so we can see better in detail what happens inside the cochlea, also with MRI, and it helps the surgeon to know which electrode he has to use, depending on the classification. He also knows which malformation has an abnormal facial nerve course, so where he has to be careful for the facial nerve, and where the gusher ears are. So then he has to seal it, because if you get a meningitis, you have a high mortality and morbidity. So it's really important to know that. Now, one thing you should not miss is a large vestibular aqueduct. It's the most frequent malformation, and of course, these patients have perception deafness. So what will you do? You will first do MR, not CT scan. So you have to recognize it on MR. These patients have decreasing hearing when they get minor traumata. So if they have repetitive trauma, they will in the end get deaf. So you have to recognize it to protect the child. Otherwise, it falls from the bicycle and so on, and it gets more and more deaf. So here, of course, because it's perception deafness, it will often arrive first on MRI. So you have to recognize it. And what you have to see is these large sacs at the back. And you see they can be filled with fluid, but also with lower signal intensity, which is the pars rugosa, which is a structure inside the aqueduct and sac. You also know that about 40% of them have abnormalities in the cochlea. You see that here. The scala vestibuli is much too large in comparison with the tympani. And if you want to measure it, you have to make reconstructions perpendicular on the apex, halfway between the vestibule and where it gets into the posterior fossa, and then you see this reconstruction, and that's the width. That's where you have to measure it. If it's more than 1.5, that's abnormal, and you know they have a large vestibular aqueduct. But the most important role of MR is to look at the nerves. And there we need another classification, because you can have a completely normal cochlea with an abnormal nerve. You can also have a perfectly normal nerve with an abnormal cochlea. So they develop independently. That's why we need 2 classifications. And we proposed the classifications years ago, saying that we can have nerve aplasia and dysplasia in 2 types. If you have no nerve at all, we call it type 1. If you have a nerve, but the nerve is abnormal, dysplasia, we call it type 2. It can be associated with an abnormal labyrinth, then we call it type 1A. If it's a normal labyrinth, we call it a type B, 1A, 1B, 2A, 2B. Now, the type 2s can be subdivided. If you have an abnormal nerve, it can be an undivided cochleovestibular nerve. That means the nerve is not dividing in vestibular and cochlear branches. Then you can have a hypoplastic cochlear branch and an aplastic cochlear branch. Now let's have a look. This movie is not running, but doesn't matter. Here in this patient, we have only an internal auditory canal without any cochleovestibular nerve going in. And we have an abnormal labyrinth. So we have a type 1, no nerve, and we have an abnormal labyrinth, type 1A. So in this patient, where is the neural tissue? You have no nerve. It doesn't matter where the tissue is, because if you have no nerve, you will never be able to stimulate. So, very simple, type 1, no implantation. Here you have another example, where you see on the left side, I have my cochlear vestibular nerve with the branch. On the right side, I have a tiny internal auditory canal, no nerve. And I see also that if I make a reconstruction through that ear, that I have a canal with one nerve. Which nerve? The facial nerve. On the other side, I have the facial nerve, I have the cochlear nerve, the superior and inferior vestibular nerve, normal. So in this patient, once again, a type 1 with a normal labyrinth, that's a type 1B, no implantation is possible. Can we look at the cochlea? Well, if you look at the cochlea, you should always have a modiolus and a base which is about 2 millimeters wide, where the nerve goes in. So in this patient, we have a nerve. Here we see no opening, and we see no real modiolus, so there is no nerve. Easy. You can even see it on CT scan. But here we have something in between. There is a modiolus, but a narrowed opening. Is there a nerve? Well, we do the MRI, there's no nerve. So you cannot rely on your CT scan. You have to do the MR to know that. And I give you another example. I have an opening, I have a modiolus, I have a narrowed internal auditory canal, and on both sides there's an absent 8 nerve. So no implantation possible. So you always have to check on MRI before you really know if there is a nerve or not. If you go to the hypoplastic and aplastic nerves, then you will see that we have a small nerve, no nerve, or a non-dividing nerve. These are the 3 types of dysplasia. So here we have a facial nerve, one single nerve going in, not splitting, and going to a common cavity. Look on the other side, there we have a facial nerve, superior inferior vestibular cochlear branch. Here we only have the facial and a non-dividing nerve. Will that work? There are, of course, nerve cells. There is a cavity. We can put an implant. You will have reaction if you do that, but we know from experience that after 3-4 years, the patient will not use the implant. So it's a waste of time. It will not work, even though everything is there to put an implant. The technique is very important. If you look at hypoplasia, then you need the highest resolution. We go further than in normal situations with our drive sequence. And in children, we will use anesthesia so that they do not move. We will use a 3 Tesla system. And of course, when aplasia or hypoplasia is suspected, we will make direct double oblique reconstructions through the fundus of the internal auditory canal, because otherwise you can't see that. That's what we do. We normally have resolution of 0.3, 0.3, 0.3. If we have congenital deafness, we go even to 0.25, almost isotropic. Then we make our reconstructions. If we see something's wrong, perpendicular on the axis on the nerve, in the axial and the coronal plane, double oblique. And then that's what you get. You have a hypoplasia, you see that here, and it's a thicker cochlear branch on the other side. If you make your perpendicular slices here, that's what you see. You see that the cochlear branch is smaller than the facial. Look on the other side, how much bigger he is. You can't cut it obliquely because we have double oblique images. And if you reformat from these high resolution, look, my inferior vestibular is disappearing, because that's a reformatted image. You have to make it directly. And if you do that with non-high resolution, 0.3, 0.3, you can guess this nerve will no longer be there. So you cannot tell anything about it. So you need very high resolution to see that. Now, my second part of the lecture is about inflammation. Now, inflammation in the middle ear, you can have acute otitis media. That's the field of CT scan, where you have fluid levels, where you have coalescent mastoiditis, abscess. You see that on CT. But once you get into the complications like thrombosis from the infection, like facial nerve palsy, meningitis, abscess, labyrinthitis, epicytis, you go to MR. Now here you see what we are doing today. Here you have an acute mastoiditis with a fuel level, and look what's happening. We see the enhancement of the full labyrinth. That's labyrinth because of the middle ear acute infection, and that's flare. Flare is much more sensitive to pick that up than T1, so we stop using T1 there, and you will see that later on. You can see the complications in these areas also if you use gadolinium. So we use gadolinium once we know there's a complication. This is a patient with a middle ear infection, a child. It developed on the infection an appendicitis, internal auditory canal. Look, everything is infected, and look at the difference between the apex right and left. It's an appendicitis. So once the infection is there, it followed the carotid down in the carotid space. Somewhere it has to get out. That's where it gets out. It's an abscess, and that's how the mother discovered what was going on, by feeling the abscess. So you see, this is where MR plays a crucial role to see how it goes around and where it actually arrives. So if we look then for the middle ear chronic infection, that's more important for MR. If you have chronic otitis media, you will start with CT. These patients have conductive hearing loss. You look at the ossicles, demineralization, retraction, tympanosclerosis. But once you have an effusion which completely obliterates the middle ear, there's no way to look at it or to use MRI. And that's where it becomes important to see if you have a cholesteatoma or other tissues in the middle ear. So, MRI. If you have complications, easy T1 with gadolinium. So here I show you why we need MR. 4 patients with an almost completely non-aerated middle ear. The first one is cholesteatoma, we can guess. The ossicles are destroyed, but it was all cholesteatoma, and you cannot know that. This is a small cholesteatoma, this is just fluid. But we know from MR. You can't see that on CT. Is that cholesteatoma? No, it turned out, this one turned out to be scar tissue, and this one turned out to be a protein cyst. You can't see on CT, you can't see anything, you're blind. So you have to use MRI. Now, how are we going to recognize cholesteatoma? If you use T1, it's low. If you use T2, it's high signal. And if you inject, it's not enhancing. But you have to wait for 45 minutes, because sometimes the enhancement of fibrosis is only after 40 minutes. So do you have that much time? Do you want to inject if it's not necessary? Because if we use B1000 non-EPI diffusion, it's high signal, and the ADC is low. So easy diagnosis with one sequence. Can we use it? Yes, because the inflammation has low and high signal on T1, T2, the same as cholesteatoma. So we have to inject. And after 45 minutes, you will see the enhancement. But do you want to wait? You don't have to. You just do the diffusion, and you have no high signal, and you have high on your ADC. So just one sequence, and you make the differentiation. And the other one you have to pick up is cholesterol granuloma, where you have high signal on T1 and T2. So you don't need anything else. But nobody uses or wastes his time today on T1 without gadolinium. So injection don't change anything, but once again, diffusion shows you immediately low signal and high signal on the ADC, different from cholesteatoma. So one sequence and you have everything. Easy, piece of cake, no contrast, no waiting, and you have the diagnosis. So what will we do? In our institution, we start with the T2 in the axial and coronal plane because it gives you the anatomy. Then we do the diffusion. High signal on diffusion means cholesteatoma. If we have that, we measure the ADC, low signal, cholesteatoma. And then, if we have a high signal, our technicians must take a T1 because we don't want to be fooled by blood or high protein concentration, and therefore we do the T1. If the T1 is low, no cholesterol granuloma, nothing. But only if there's a high signal, otherwise we don't even need it. If you have complications, and you see the list of complications, we use T1 with gadolinium. And here you see cholesteatoma, it got through the tegmen, and therefore you get a thrombosis. Thrombosis, easy to pick up, that's where MR plays its role, and you can easily detect them. Here another example of a complication, small cholesteatoma. Inflammation around it gets through the roof, and you have a middle fossa abscess. Gado, enhancement, easy to pick up. So once you get into trouble, use T1. There is, of course, also the fistula towards the lateral semicircular canal. The patients get dizzy when you push on the drum, and so here you see the fistula on CT scan, and on MR you see what's happening under it. It can be fibrotic under it, that's more safe to do surgery, or it can just have fluid under it. Here another fistula to the lateral semicircular canal. You see the fluid, and that's more dangerous to perform surgery because you can lose the hearing if you open that membranous labyrinth. Now, just to show you how important MR today is, this is a patient that had a cholesteatoma on the right side. He had surgery, and now they want to know if he has a new cholesteatoma. T2, T1 with gadolinium, and you see nothing. I can't tell anything. That's too difficult. But on the other side, where he was not operated, we see high signal and low after gadolinium. So they have something there. It has been missed before. We do the non-EPI, and suddenly everything is easy. We have a congenital cholesteatoma on the left side, and that's a residual one on the right side. So now we need CT. Now we are allowed to irradiate the patient. And we see this. If you would not have MR, would you make that a cholesteatoma? Now here you see the congenital cholesteatoma, and that congenital one is going to attack the ear, so you're going to have a deaf ear. So you should first operate that. That's what our surgeon did. He went in and he took away the one on the left side. But you see on our control MRI, there's still residual also on that side, so he missed something. So what did he miss? That's the facial nerve. This is debris from the surgery, and this is cholesteatoma in a sealed cell with bone above it. He couldn't see it. So he has to go in again. So he needs a new surgery, and we check again, and now he has dissected the facial nerve, and there you see that we actually see the cholesteatoma is gone. Now he does the other side, and on the other side he also takes it out, and everything's gone. Just imagine you have to do that without MR. Impossible. So you see today the diagnosis is made on MRI, and what we do actually is we do the non-EPI, we do the cone beam CT low dose, and then we fuse them, and then you know exactly where the residual cholesteatomas are. So the surgeon has the roadmap, CT, and he knows exactly where to go to take out the cholesteatoma. Last point is the inner ear infections. If we have infections in the inner ear, they can be viral. These ones do not get fibrosis or calcifications, or they can be bacterial, pneumomeningococcus. They calcify and give fibrosis. And you have acute ones, where you have only enhancement, subacute fibrosis, and the chronic will calcify. I give you examples. Here we see the enhancement of the cochlea and the vestibule, and of course, it's fluid, gadolinium and labyrinthine fluid, so we see just fluid. Nothing's visible on the T2, you have to inject, or you can't see the acute labyrinthitis, so CT will not work. If you have bacterial infection, it comes most often from the middle ear, it can jump to the apex, we've seen that, but also in the inner ear. Look, it's enhancing in the cochlea and the vestibule, and here you see normal fluid, but we start to have fibrosis in the vestibule. See that? So that's subacute. And then you come, of course, to the chronic one, and the chronic one, it gets calcified. And you see that on CT, in the scala tympani, the vestibule is normal. We see on the T2 of the MRI, you see the loss of fluid, but it's still there in the scala vestibuli. So you don't need MRI. Oh no, you do. In the same patient, we have higher up the cochlea, and you see in the second turn a normal anterior part, but if I look on my MR, there's fibrosis which is not calcified. So I have a combination. So you need both to know exactly what's going on before you put in an implant. Otherwise, you will miss that, and the surgeon will be surprised and can't do his thing. Now, the routine sequences we are using today for disinfection enhancement is 3D FLAIR. Much better than T1, and we use gradient echo T2 to see the changes in the fluid, the fibrosis, and not the high-resolution turbospan echo, which we reserve for anatomy, like aplasia or dysplasia of the nerves. And here I give you the example why. This is the same patient the same day, with infection, sudden deafness on both sides. And you see on the right side, I have some enhancement in the basal turn, but look on my FLAIR. And on the other side, I have almost no enhancement. I would make that normal. And look on my FLAIR. Everything is enhancing. So much more sensitive. So detection of infection today, that is FLAIR. And if you look at this changes fibrotic, the turbospan echo shows you normal fluid. And here you can already see the fibrosis on a gradient echo. So the future of the infections of the inner ear are completely FLAIR and gradient echo T2. That's what we are going to use. And the last example on that is, look at this. You have the perilymph is yellow, and the endolymph is a much smaller space. This is the utriculus, this is the saccule, and these are the ampullae. And with the gradient echo, look, we make a 3D reconstruction. You see the high signal only in the utriculus, saccule, and ampullae. So this fluid is normal, and the perilymph is abnormal. This patient has done a perilymphitis, and the endolymph is normal. And you see the protein changes only in the perilymph. Just to show you how far we can go with that detection, with the right sequences. So in conclusion, For congenital disorders of the middle and inner ear, well, we can detect more subtle intralabyrinthine changes, incomplete partition on MR than on CT, but the major advantage is, please, before anyone does anything, make sure your nerve is normal. That's MR. Inflammation of the middle ear, well, MR can characterize tissues in non-aerated ears, and therefore we can make the diagnosis of cholesteatoma. MR is the best method to detect complications, and there we need T1 with gadolinium or FLAIR, because it's so sensitive. And for inflammation of the inner ear, well, acute and subacute labyrinthitis are only visible on MR. So the majority of labyrinthitis is invisible on CT. And the complications, once again, that's the world of MR with T1 Gado and FLAIR. I thank you for your attention.
I'm going to invite the panelists to come up for questions. While they're coming up, I'll ask Jan a question. How come we don't have an issue between not being able to distinguish an abscess in the temporal bone from a recurrent cholesteatoma? Would that also be brighter on DWI?
Exactly. I'm glad you asked the question. There are two booby traps, and the two booby traps are abscess and cerumen in the ear. But they are both easy to find. The first one, the patient comes in with pain, has a red ear, and it's hot, most often. You have the clinical signs which are completely different and clinical. For the cerumen, if we have a doubt, we send the patient back to the ENT surgeon, they clean the ear, and we do it over again, and then we know it's not cerumen.
Questions from the audience? Yeah. Sit down. So the question is about the CIS imaging post-gadolinium. Is there a delay time? How do you perform the study? Do you have to wait a little bit of time afterwards?
No, we don't use a significant delay typically. So we use centric case space filling, and usually within 30 seconds of contrast injection we start. The parameters are actually listed in one of our recent articles. If you look online for the handout for today's session, you'll see mention of the recent publication we had in Radiologic Clinics of North America that mentions some more about the protocol. Thank you.
Yeah, this is regarding perineural spread. Now, as a default in other tumors of the body, we use TNM classification, and we proactively look at lymph nodes, metastasis, and then stage the tumors in any other part of the body. But for the squamous carcinomas, as you mentioned, as well as the adenoid cystic, which are the common ones which spread perineurally, is there a case for introducing, or as a default, proactively looking at perineural spread and including it as part of the standard staging, rather than wait for neurological symptoms?
I think that's an excellent question and suggestion. I think that given the higher rates of recurrence of disease and worse prognosis, I think our sensitivity in the past for perineural spread hasn't been as high as it can be, and it will be interesting to see as our techniques are changing if our sensitivity and specificity doesn't increase as well for that. But I think it's an excellent question.
I'll ask a question of Pat. I mean, usually the issue that I run into is fungal infection versus tumor, and some of your findings where you have bone destruction you can see with fungus. So any tips on making that distinction?
We definitely like to see low signal on T2. We always get an MR, if at all possible. The fungal infections that are invasive are often just in the anterior nasal cavity, so they're pretty easy usually to access. But I love MR. They're very dark on MR, and they don't enhance. So that's another time that gadolinium is helpful when you're dealing with an aggressive-looking sinonasal process. The black eschar of fungus doesn't enhance.
Pat, can you just answer the question?
And then somebody asked me to clarify for the 5 millimeter thickness for intradural disease, and it's been described for the depth, not the width. So you can have pretty wide along the middle cranial fossa floor, but it's the depth of 5 millimeters. All of that data is very old and really will need a multi-institutional relook at that now that our surgeons are doing more craniofacial resections. David?
Yeah, I know just how old it is since it was back in 1992 when I was at University of Pennsylvania.
Remember I emailed you about it.
Quick question for the panel. Any of you have experience with using intratympanic gadolinium on the issue of Meniere's disease?
Well, I hope there are not too many Japanese in the room, because that's a technique that actually only got off the ground in Japan. Because you have to lay down for 24 hours, they have to inject you through the drum. This was not acceptable. I tried to convince my clinicians to do it. They refused. But forget about it. Today we have 3D flare. You inject, you wait for 4 hours, and you can see it intravenously. So why the hell would you go intratympanic? We do about 15 patients a week now. So it's a new technique. It's an article from Barak. 4 hours, sorry. I say 4 hours, just 4 hours. We do a double injection. We do double dose in IV. And since we do that, we do 15 a week, or clinicians, they are fond of it. So please don't inject intratympanically. It's not needed. It's not needed anymore.
Okay, I gotta give Minerva a chance. So, how do you think about the inflammatory, lymphoproliferative inflammatory lesions in the orbit? Because now a lot of people are just calling these things IgG4 lesions. What's your way of thinking about it?
Well, some of these lesions, they are classified as IgG4, but there have to be very specific histologic signs and very specific patterns of spread in the pancreas, other salivary glands and all that. And also the blood samples will give you a clue to that. In terms of differential diagnosis, most inflammatory pseudotumors behave just like IgG4. So what I would do in the report, I say inflammatory pseudotumor not otherwise specified versus IgG4, and then they will go and check the peripheral blood, and that's it. Then they treat with steroids.
Yeah, okay. I have a question about the cisternal segment of the cranial nerves. We see these days the clinician asking for the vascular compression over the cranial nerve. What's the criteria? Because we see so many vessels coming around the nerves. So when should we consider as those vessels compressing nerves that are causing the neuropathies? Yeah,
thank you. I didn't get a chance to talk about it, but a large part of what we do is actually trigeminal neuralgia imaging. And we have a paper submitted retrospectively where we've looked at that. Other people have published on this. And just contacting the nerve itself is not specific. That happens very frequently. The prognosis after treatment is much better if there's actually deformity of the nerve. And I've shown you today CIS imaging before and after contrast. We use this as well for looking at neurovascular compression. And you'll see, just as in the case of the second nerve deformed by the meningioma, you can see the cisternal segments of the fifth nerve, for instance, separate from the blood vessels and deformed by the blood vessels. And we think that that's helpful and more specific for the question that you asked. Thank you.
Just a quick note on that. One of our serious responsibilities in that setting is making sure there's not another cause for the trigeminal neuralgia. I mean, it's tragic, some of the cases I've seen where people have had ablations and craniotomies and blah, 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 and they've got, floor of mouth cancer or a big tumor in the cavernous sinus. So if you don't have the expertise to look for contact or the cisternal enhancement, really be on your toes for looking for other explanations for trigeminal neuralgia.
Just to add a comment on that vascular compression syndrome or neuralgia, there's a poster out there available that shows symptomatic relief with a Teflon placement between the nerve and vessel, and it protested by the presenter that a symptom was relieved by the therapy. So there's a potential benefit to that point well taken.
Yeah.
So the comment was that there's a poster that demonstrates that doing neurovascular decompression, inserting a pledget between the vessel and the nerve can be helpful in relieving symptoms. And that is true, and it's more true when there is deformity of the nerve, particularly as visualized on post-contrast cis imaging we've found. So yes, that can sometimes certainly be helpful.
Well, we have just very few data on them, but basically they're just the same as for inflammatory pseudotumor otherwise. And also it's very difficult to differentiate between the two, because until recently, histologically, everything was just pulled together. And some people speak about sclerosing inflammatory pseudotumors, which are in fact IgG4. Others speak only about IgG4. So actually, I think that we would need perhaps some new data to really classify according to the new classification what's exactly IgG4, what's exactly inflammatory pseudotumor otherwise. Yes.
My opinion is that IgG4 is a serologic workup. You know, they really need to have a rheumatologist drawing their IgG levels, their subtypes, IgE. If they're negative, you repeat them again before you go to biopsy, because it really is a serologic workup, in my opinion, not just an imaging workup.
I just want to thank Dr. Stroller for allowing me to host these wonderful speakers, and if you have any further questions, they'll take them up front. Thank you very much for attending the session.